dogs, but that's not slowing, that's just the GTHG code. GTHG? Yeah, or any calcium dioxide surgery. No, I didn't.
What are usually Wednesday? Tuesday? No, Wednesday.
Today is Tuesday.
Yeah.
Tomorrow is Wednesday. Today is your last day. I think tomorrow you don't have any, like that. Thursday is a holiday, right?
Mm-hmm. Yeah.
Thursday is holiday. Or tomorrow is holiday.
No, Thursday.
Thursday for us, yeah.
But tomorrow's our last day of dermatology, and then we go on to rheumatology.
Is this still weather like this all year round, or
It's hotter.
it's not that hot? Humid.
I'm worried about this.
It's humid. It's nice. You won't get dry skin. But how about rainy? Is all raining all year round?
No, they say August to January is rainy season, and then February to July is hot season.
That would be hot season.
Yeah, right now it's rainy season. At all.
Oh, you went through?
Huh?
You went through the step one?
No, it's like, I thought you guys said 2.5 weeks. Yeah, for the exam? Yeah, it's not enough time at all. Bro, I wish I want to ask him to give us like example U-World questions of anatomy. Because he said the way it's going to be is if this muscle gets hurt, if he can't do this, then what nerve is hurt? I just want example questions.
You can probably post them up on Bachelor. Johnson.
Yeah, answers right.
Rough idea.
How would it look? Yeah, that's not what I want.
You know, like maybe probably be a little less complicated.
Yeah, you can't press your shoulders. What is the nerve affected? Fuck, man. I remember the other thing I was accessory. Trapezius accessory.
Well, I already forgot all of that.
That's how you're bored. You got a lot more stuff there.
Ah. You
So
told me to go over
you
brachial plexus.
finally got to it. No, that was me.
Okay, sorry. You told me to go over
Friday 8 a.m. and 1 p.m.
Oh, you guys,
student
I saw these
association meetings.
slides. I read them.
Yeah.
There's the
go on.
NCC, National Comprehensive Cancer Network. It's in December.
No, I
But
watched
if you,
them.
if it's virtual or in
Whatever
person,
they're saying.
it's in Philadelphia, so you gotta go to
Is
it.
it?
It's on the,
But I've like 10 minutes left. No, but I'm saying like.
Could you send me
If you read the
3 p.m.
slides.
lecture.
yeah, I'll send you the information.
And then not only that, yeah, but
I don't fuck with 2 p.m. lectures now. I like 3 p.m. lectures.
And then, on top of that, you were supposed to understand that, like, there were, let's say for instance, one part isn't working, you wanted to know what the disease is associated with, and like today I'm gonna go with black spots.
You also know the most movements of the dermatology market.
And then they
So it's really good to do. Start now.
What's this?
we read ahead.
Oh, well, no. For next week, this week.
No, for
that's
today.
today.
For today.
Today, go with that.
Okay, most probably the rain has washed the half of your group, so we are stick with this remaining half. And then today we are going to talk about these basically very common diseases, contrary to what we talked previously that are very rare or rare. These are very common problems. And this first one is acne. So acne is a disease of the pilosebaceous follicle. This is a diagram of the pilosebaceous follicle. Can you name the different part of that? From the first day, can you name that one?
Sebaceous gland,
Uh-huh.
the hair, root,
Trend?
Erector pili.
and the rector pili. There we go.
So, basically you have the follicle divided in three parts. From the top surface epidermis to the opening of the sebaceous gland,
Sure.
it's called infundibulum. Okay, this is the infundibulum. From the opening of the sebaceous gland to the attachment of this erector pili muscle, it's called isthmus. And this is the lower segment, right? These two parts are constant. They're always there. This lower part is cycling. So anytime when the hair is growing in anagen phase, it starts to come down into the dermis, and this dermal papilla from below attached to that one, the cells start to proliferate and produce the hair shaft that grow. And then when it goes to the catagen phase or resting phase, telogen phase, this lower part will shrink and comes up to here. And here we have a little bulge, that is the stem cells are there. So in each new cycle, the cells start from proliferation from here and then create the pilosebaceous follicle again. So this part is moving, cycling, up and down, right? But these two parts are constant. We have the sebaceous gland, and not in all the places, some specific places like the major body folds, armpit, under the breast, genitalia, you have this apocrine gland that they are opening to the hair follicle. And then we have the eccrine gland that goes directly to the surface of the skin, right? So, in the acne, we have pathology in this opening of the follicle and the hair and the sebaceous gland. Okay? So let's look at these pictures. I hope that you already have gone through this presentation yesterday. So what we have here?
Acne.
So what is called this one?
Comedones.
This is comedon. Which kind of comedones? Open comedones,
Oh.
on blackheads, right? So there are 4 elements in developing the acne. First one is this keratinization of this follicular opening. So the cells over here proliferate and they stick together, so make a clot. So this clot is the first step in developing the acne. The second pathogenesis is this hyperproliferation or hypersecretion of the sebaceous gland. So this sebaceous gland start to increase their secretions, and then as a result of this oil, full of oil environment, then the bacteria that one of the normal flora of the skin called Cutibacterium acne is an anaerobe, start to grow in this unfavorable environment and produces some enzymes, some byproducts, and then create some free fatty acids. And then as a result of all these things, you have inflammation. These 4 elements, hyperkeratinization, secretion of the sebaceous gland, inflammation and bacteria is very important, because when we come to the treatment, we are going to address each of them by our medication. And sometimes we use medications to address several of them at the same time, right? So what is the drive of all these changes? Follicular hyperkeratinization, increase in sebaceous gland activity. What is the drive over here?
Androgens?
Androgens, right? For this reason, usually you see these acne lesions around the time of the puberty, when the gonads start to, and the adrenals start to produce more androgen, right? So keep that in mind. We can have two kind of increase in androgens, simply. Sometimes this increase in androgen is locally produced over here, because these cells of the sebaceous gland and also these cells of the keratinocyte and the follicular epithelium have the enzymes that convert the normal androgens like a testosterone or dihydroepiandrosterone, weak androgens, to the dihydrotestosterone. It's a strong androgen. And then this happens genetically, and it doesn't happen everywhere. For this reason, you see here, not all the follicles are involved. There are some skip area. There are follicles that are not responding, okay? And there are some situations that you have generalized increase in androgen, right? You have increased level of abnormal level of the androgen. Like what, for example? Pregnancy is one of them. What else? Polycystic ovary disease, for example, right? Polycystic ovary disease, or sometimes even
Thyroid disease?
not directly, but indirect, yeah. But for example, tumors like adrenal gland tumors, gonadal tumors, they can produce excessive androgen, and then this excessive androgen also stimulates this process, right? So genetic is a big important factor. Acne runs in the family. So if your parents have the acne, most probably you are going to have the same thing as well. So when this clot happens here, what we have, the early lesion, is the comedons, right? So if this opening is dilated, you will see the accumulation of the sebum and keratinocytes in this opening, and you will see this black color because of the melanization, oxidation of the melanin. If this pore is still remain closed, you will see this accumulation under the follicular opening, and it makes a white head, right? Or closed comedon. So we have open comedons, and then we have closed comedon. As a result of this inflammation that goes on here, you will develop some inflammatory lesions like a papules, like a pustules, right? Which area of the body you usually have the acne?
Face?
The area that have more sebaceous glands, right? Face, upper chest, upper back, right? These are the areas that you have more sebaceous gland, oily part of your skin, so definitely you have more acne on this area, right? Which age usually we have acne? Puberty, right? It starts usually on the puberty, and so as I told you, very common, something around 80–85% of the adolescents, they have some acne lesion. But other age group, for example, may have acne as well. For example, we have acne in children, in childhood acne. The childhood acne is divided in 3 or 4 phases. For example, we have a neonatal acne that starts from the birth to the first 6 weeks of life. In those period of times, the sebaceous gland is very active because of the effect of the maternal hormones, right? Then you have an infantile acne that is from 6 weeks up to 1 year. This is common in males, and then this is because of the premature activation of adrenal gland that produce androgen again. Again, this is something normal. Then we have the adrenal or early stage of this puberty that starts around the age of 7 or 8. Then the body itself starts to produce androgens, and then you slowly have some acne. This is called peri-adolescence acne. And then the adolescent acne is from 12 years to 18 years. In the period between 1 year to 7 years, that is called mid-childhood acne, you shouldn't have any acne because there is no effect from the previous hormones from the mother side, and your own body has not started to produce hormone yet, right? So if you see any acne this mid-childhood, it means investigation. to find out is there any reason why is the acne happens, what is the cause of this androgen that produces that one. So this androgen is a very key important factor over here. So now in a lady, for example, if you have excess androgen, what other signs you may have? Hirsutism, right? You may see some hirsutism. So for example, or what else? For example, ladies, irregularity in the menstrual cycle, right? Oligomenorrhea, or for example, stopped menstrual cycle. For this reason, whenever you see an acne again, you are going to investigate to see if you can see any other sign of this hyperandrogenism, like hirsutism, like a menstrual irregularity, that guide you to what a systemic cause for this excessive androgen. And then is there any investigation or any lab test or any workup is needed or not, right? Okay, let's see what we have here. So we grade the acne different. Sometimes the acne is remaining papulopustular, but you have some more inflammatory lesions, like for example these nodules and cystic acne, right? So the intensity of the acne can vary from comedonal acne all the way to nodulocystic. Does everybody go through the cycle? No.
No.
Right? Some people may start from the papulopustular, remain on the same phase. Some people may go to this severe inflammatory situations. And then we have one acne conglobata, that usually is a nodulocystic acne. And when we have this acne fulminans, this usually a very rare, severe form of the acne. Usually they have erosion and cross formation. You see, this is different from this one. This is erosions. And this usually comes with the systemic symptoms like fever, like joint pain. They have this kind of things. So, what are the complications of the acne? Scarring. Scarring. You may have different kind of scarring. You may have atrophic scarring, you may have hypertrophic scarring, and even this atrophic keloid and then this atrophic scarring is subdivided, for example, to this ice peak scarring, like a sharp small points like that, or for example, this rolling, or for example, like this boxcar scarring. These are the shape. The treatment-wise, they are a little bit different. Modality, you can use that one. But scarring is a very common, I can say, complication of the inflammatory acne. And then what else you can have? Post-inflammatory hyperpigmentation. This happens especially in the people who have dark skin, right? And in white skin, you have post-inflammatory erythema, means that the redness after the lesions are cleared, this redness will remain for a very long time, right? So the reason we treat acne is because of prevention of this complication. Usually, typical cases, the acne starts at the age around puberty, something around, for example, 12, 13, 14 years, and is active for a decade, for 10 years. And after 10 years, it stops by itself, right? So what we do here, in most of the cases, we try to control the acne to prevent these complications to happen. So most of the parents come and say, why we should treat or the acne, because this will go away anyhow. Yeah, but they leave the scars, they leave the pigmentation, and these are very hard to treat, very hard to treat. So basically the main goal is to control the acne to prevent from these complications to happen, right? Okay, so one of the variants of this acne is this one. What you see here mostly, excoriations. It's called acne excoriate. Means excoriated acne. These are usually happens in young females who have mild acne, but they obsessively pick them and they end up with some scarring and some pigmentation. Right? This is one of the pictures of the young females. We have age-wise one adult acne. This adult acne calls hormonal acne. Of course, I told you all the acne are hormonal, right? But this is adult acne. Usually happens in the ladies after the age of 25. And it can be either the continuation of the acne they have from the adolescence, or for the first time appear after the age of 25. This adult acne usually sits on the lower part of the face, on the jawline. This is the common place for this adult acne. And they are somehow related to this hormonal irregularities. Most of them have some hormonal issue, but not overt. For example, hyperandrogenism is seen in every cases. So this is the infantile acne. This is the neonatal acne. In neonatal acne, you will see just some like closed comedons, right? You don't see any small papules. You don't see any comedons. This is an infantile acne. You will see all the lesions of the acne, comedons, papules, pustules, and this is a mid-childhood acne that has underlying endocrine problems, right? So here you are always investigative. You see between the age of 1 to 7. So what are the differential diagnosis of the acne? What lesion can look similar to the acne?
Chickenpox?
So let's go back to this previous slide over here. And then somebody comes in like this. How you define these lesions?
The comedonal?
This one.
Oh, no.
This is basically follicular, means all the lesions happens around the hair follicle, papules and pustules. So it says an inflammation of the follicles. What's the name of that? Folliculitis, right? This is a folliculitis. This is the folliculitis caused by acne. But we have other kind of folliculitis. We talk about here, fungal infection can cause folliculitis, viral infection can cause folliculitis, right? Sometimes irritation can cause folliculitis. Sometimes medication can cause folliculitis. And then another skin diseases over here, the rosacea can also have some follicular papules and pustules, right? So what is the characteristic of this acne? Acne folliculitis that you can separate it from other causes? Comedons. For this reason, it's very important. If you see folliculitis, you want all the differentials, and then you find out is there any comedons is there or not. This is definition of the acne, right? Why you're laughing?
Oh, because I had said it and I was.
No, you just said comedons. We are talking about the folliculitis. This part, right? Comedons is specific for the acne. For this reason, anytime you want to check, make sure that you see that. If you don't see the comedons, this is not an acne. Mostly, it will be an acne-form eruption, like this one, right? Like this one. This is an acne-form eruption. You will see some similar lesions to the acne, papules and pustules, but you don't see any comedons, right? This happens, for example, when you take some sort of medications like oral corticosteroid, like anabolic steroid, like androgen hormones, some sort of medications like isoniazid, they can produce acne-form lesion. And this clue here is that you don't see any comedons, right? We have some specific type of the acne lesion. For example, one is called acne mechanica. This mechanica means that if something rubs the skin, irritates the skin, stimulates the skin, you may develop some acne-form lesion at the site of that. You will see, for example, somebody comes with a little bit acne here, and you will find out that he wears some helmet or some sort of the things that covers that skin, and then sweat accumulates there, and then rubs that skin, and then produce this kind of things. Another form of acne is the people who put oils on their skin. It's called pomade acne, especially dark skin people. For the managing of their hair, they put lots of oil, and then if oil comes and covers the face, then it produces a favorable environment for this bacteria to grow and produce some sort of the acne. You will see this only on the hairline and mostly in the closed papules, right? So these are the variant of the acne. How we are going to treat the acne? What are the basic treatment for the acne?
Steroids.
So this steroid is the only thing that we are not going to give. If you want one product that you want to stay away from, that is the steroid, because the steroid is causing acne, right? So I told you we have some problem in this follicular hyperkeratinization, right? So one modality is to address this follicular hyperkeratinization. You want to give some products to normalize the keratinization, normalize and let the skin shed, like retinoid products, like retinoids, adapalene, tretinoin. These are the products that you can use that normalize this one. Then you have bacterial overgrowth over here, right? And this drives the inflammation. You will give you antibiotics, some topical antibiotics, some oral antibiotics. These are helping to control the number of the bacteria, reduce the inflammation. Also, for example, you can do superficial peelings, or for example, some products like salicylic acid that again remove this hyperkeratinized epidermis from it. So you remember these 4 elements, and you want to address each of them with a particular medication. And the king in acne treatment is oral retinoid, that's oral isotretinoin, the famous Accutane, that addresses all 4 elements of the acne, and is the only medication that can change the course of the acne. Basically, it cures somehow, you can say, the acne. Yeah.
But with Accutane, isn't it like a last resort if you guys have tried everything else?
As I told you, this is the medication. This is the most effective one, but it comes with the side effects. So the most important side effects that you need to remember is teratogenic potential. So isotretinoin, basically, if you want to prescribe for a lady in childbearing age, should have 2 different way of contraceptive simultaneously. Okay, so that is a highly teratogenic medicine, and it has some systemic side effects. Sometimes may increase the lipid levels, may, for example, sometimes hurt the liver, so you need to do some investigation. But that is the most effective treatment we have. Remember again, the goal here is to prevent the complication, especially the scarring. The scarring is something that, because this process of the acne happens in the young people, and then this scar face live with them for the rest of their life, right? Take this appearance, as we are in dermatology field, take this appearance really seriously. Recently there was a publishing articles that they say all the villain characters in the movies, they have acne scars, or they are bald, or they are some sort of these impurities, right? And this gives a general impression that, for example, these people are dirty, they are not clean, they have some issues. It really matters, especially in today's world, that everything is on the surface, right? So everyone wants to look nice. So it's very important to take care of this whole career, life, future of somebody, young people, by treating their acne on time, properly, prevent from these things to happen. So it is not just a matter of just small folliculitis or some impurities. Okay, I think we covered everything in the acne world.
Rosacea.
And then move on to rosacea. So rosacea, again, is a chronic inflammatory disease, but it is not follicular centered. You will see some papules and pustules here, but generally it is not centered around the follicles. It's usually seen in the middle life, something around age of 30 to 50, more common in females, more common in white skin people, but it can see in males, it can see in black skin as well. So have you seen anybody who, for example, flushes suddenly, especially if they are angry? Anybody around you? Because these people, one of the hallmarks is this flushing, right? So if they become angry, if they become emotional, they become like a tomato red, very red, right? Or for example, if there are some triggers like drinking alcohol, hot coffee, hot tea, spicy food, they really become red, okay? So the hallmark of this rosacea is this vascular hyperreactivity. The skin is very reactive. So one of the pathogenesis in this rosacea is dysregulation in vascularity, right? So they have overactive vasculature, especially in the superficial dermis, and they have some excessive angiogenesis. They develop some new vessels, right? So they develop this telangiectasia, red blood vessels. You will see these are the telangiectasia. This is because they generate new vessels, right? Another important thing in the pathogenesis of the rosacea is that they have some dysregulation in their innate immune system. This innate immune system, some part is producing of the antimicrobial peptides, like a catalycidine, like a kallikrein, that they usually work in a defense system against the superficial organism, but if they are produced in an increased amount, and especially, for example, if you have increased expression of toll-like receptors on your keratinocyte, they can produce pro-inflammatory mediators and cause inflammation, right? So we have one important factor is the vascularity, instability, and then we have this dysregulation in the immune system. And another factor over here, again, is some sort of microorganism. But here talking about mites. These are like a small, tiny worms that lives on the human hair follicles. This is again a normal flora. Everybody has that. But sometimes they can irritate the immune system, and especially there are some bacteria living inside the gut of that mite that cause the problem, right? So this combination of these factors leads to producing of the inflammation that drives the rosacea. Rosacea, again, is a chronic disease. It's a long-lasting disease, and it has fluctuating in severity, wax and wane, right? And we divided the rosacea in several subtypes, right? The first one is the erythematotelangiectatic, ETR. It means that they have fixed redness, burst of flushing, and you can see some telangiectasia. Another subtype is this papulopustular. You will see papules and pustules, especially in the mid-face, cheeks, nose, chin. These are the commonly affected area. This looks like acne because this is papulopustular. But what is the difference here?
No comedonals.
No comedonals, and age-wise, yeah, this is a middle-aged lady, 40, 50 years of age lady, and there is no history of the acne before, so you can differentiate these two. And also, what is this? This is rhinophyma. This is a phymatous chest that can happen on the ear, can happen on the nose. Over here, as a chronic inflammation, you have excess skin, and this excess skin produces excessive bigger oily glands and also some fibrosis, and develop this appearance of the big nose with nodularity, irregular sort of surface. This is rhinophyma. Another name is whiskey nose, right? And then you have some ocular involvement. Eye involvement is another subtype of this ocular rosacea, is another subtype of the rosacea, and they usually complain of this feeling of foreign material in their eyes, irritation, sometimes redness. These are the different manifestations of the rosacea. Okay, so let's see what we have here. Now we have a couple of red faces. So, which one is rosacea? And what is this? What you see here? Here.
Yeah, there's.
You will see an erythematous. See the border, erythematous, scaly, not very scaly, little greasy scaly in the mid-face, right?
Right.
Which one of dermatitis is this?
Oh,
Seborrheic dermatitis. So this is seborrheic dermatitis. You will see that it looks similar, right? You see the involvement of the nasolabial fold. You will see erythema, scaling, little bit patches involving the center of the forehead, eyebrows, forehead, and then you may have some lesions on the scalp and navel. How about this one? How do you describe this? Fabulous. And what is this?
Lupus.
Lupus. This is an acute lupus. Again, you will see an erythematous patch, sometimes plugged with little scale or crust, but no papule and pustule. In lupus, we do not have papule and pustule. So anything papular and pustular is not lupus. Anything involving these two can be in the differential of each other, because here it can have a little bit of scaling. If you get close to direct vision, you may see the same character here. But in the seborrheic dermatitis, you have involvement of the nasolabial fold. Here is a square, right? And how about here? What is this?
Parvovirus?
Rosacea, right? You will see erythema, and you will see some chin involvement, and you will see some papules on this side, right? So these are the different. You can see this. By first look, they look very similar, but they have each their own characteristics that you can differentiate from each other. And how about these ones? Which one is rosacea?
The third one.
The middle one.
So let's describe this. What do you see here? You will see again an erythematous scaly, right? But it is very sharp border, more active on the border. You will scaling at the border with some central clearing. So imagine an annular lesion. The annular lesion always is not small. Sometimes can be a large annular lesion with the sharp border, active border, scaly border, which is tinea. This is the tinea fasciae, right? It's about, when you see this border, it's a tinea fasciae. And how about this one?
Vitiligo. Rosacea.
Again, what do you see here? You will see an erythematous vesicular oozing plaque, again with the sharp border. And it could be contact dermatitis. Right? Somebody put something over here, you develop a contact dermatitis. And how about this one? What do you see here? Same story. You will see tiny papules and pustules around the mouth, but it has doesn't involve just around the vermilion border. You will see a rim of this around the lips, perioral. This area is not involved, right? This looks similar to the rosacea, but you do not have any other sign of the rosacea here. This is a perioral dermatitis. This is, you can say, a variant or something related to the rosacea. This perioral dermatitis, again, is common in the young people, especially ladies. Same story, you have tiny papules and pustules located around the mouth, and sometimes they extend to come around the eyes as well. For this reason, we call them periorificial. Means any orifice on the face, you will see the same lesion around there, right? It could be seen even in the children as well. The cause of this, one of the main causes of this is putting cortisol, corticosteroid creams, or sometimes putting different kind of the cosmetics, right? So here the treatment will be to stop, first to identify the reason, stop this culprit, and then you use, for example, sometimes antibiotics, topical or oral, or something to reduce the inflammation that here we can use instead of cortisone. Which kind of products? Calcineurin inhibitors, tacrolimus, pimecrolimus, they can use over here to reduce the inflammation. Okay, what we have here? Again, same story of the red face. For example, and here, what do you see? Okay, again you will see what's called this?
Scaly patches.
It's a papule, right?
Yeah.
When it's a scale, there is no patch. Patch is only the color change, right? When you see the scale, it's a papule. So you have this erythematous, scaly, sharp, defined border. And what is the character of the scale here? Character of the scale? Silvery scale, right? What is this? Psoriasis. Psoriasis can involve the face as well. Although usually psoriasis is not comes in the, it's very rare to come in the exposed part, but it can extend from the skull, come to the forehead, right? And what is this one?
Vitiligo.
What you see here again, the reason is that you are not again, you see how many times I'm trying. First you have to define. What do you see? You will see a dry, chapped, right? Had plaque with a sharp border that involving even the vermilion, right? So dry, scaly, sharp border, plaque, again is a contact dermatitis, but this time it is an irritant contact dermatitis. Because here is a direct damage to the skin. This is the difference between the allergic that goes from inside, you will see vesiculation, oozing, edema, and from the irritant that has a direct damage to the skin, so you will see dryness, the epidermal barrier function is gone over here, so you will see dryness, chapping, and you will see some scaling, and this is mostly burns rather than itch. What could be the cause of this?
Poison,
What could be the cause of this?
contact dermatitis.
Yeah, it's a irritant contact
Nickel,
dermatitis.
something that could be, that you put on your face, lip balm.
Chap.
Acne.
Could be a topicals,
Yeah,
right?
yeah.
Any topicals you put, but do you think that this boy is going to put lipstick on his lips?
No, I thought it was a girl. So I said chapstick.
This is typically is lip licking dermatitis.
Really?
People keep doing that. And then if you do that habitually 1 or 2, 3 times, this saliva will burn the skin, you feel dryness, and the more you dry, the more you this.
And that's a type 4 hypersensitivity.
This is an irritant contact dermatitis. This is an irritant. This is only because of this saliva and its content damage the barrier function. It's called lip licking dermatitis. And then with this child sitting in front of you and you say that you do this, yet no, constantly doing that. Because you feel dry and they bring the water out of the mouth to make it wet, to make it comfortable. And the more you do that, the more it becomes worse.
This was me as a kid.
Okay? So, in Rosacea family, we have a condition called pyoderma faciale. This is a sudden appearance of multiple pustules, nodules, very inflammatory region. It's common in female, you can see again on the male as well. But here we don't have any systemic symptoms. But they have a very exuberant manifestation, sudden appearance of so many inflammatory lesions on their face. This is one of the severe form of the rosacea. So, what will be the treatment option for the rosacea?
Avoiding triggers.
So you have this papulopustular, and we talk about this bacteria that, or these mice that can cause this one. These are involved in that, so you can use some sort of antibiotics or antiprotozoal, like for example ivermectin that kills the worm, right? These has some role in treatment of that. And then you have this redness because of this vasodilation and increase in vascularity or flushing, that you can use something to shrink the vessel, right? What you can use for the shrink of the vessel topically?
So it's azelaic acid.
Azelaic acid again is the, no, this is not for the azelaic acid. Azelaic acid is anti-inflammatory.
Alpha blockers.
This is Agnes.
Alpha blocker or alpha agonist. Alpha agonist, right? If you if you stimulate the alpha receptors, it causes vasoconstriction, right? So alpha agonist, like for example, what? Brimonidine and
Oxymetazoline.
oxymetazoline. Okay. So these are the products that you can use, and also you can use energy-based device like a laser and like devices to shrink and to reduce the number of the vessels as well.
Oh.
Okay. So again, a couple of these red faces. For example, what you have here?
Continue. Erythematotelangiectatic patch.
No, it's elevated.
Elevated plaque.
Plaque.
So it's an edematous, it's an edema and erythema. Again, look at this very
Wait, is it
nice sharp border.
Is there fluid in there? It looks
It's not a fluid, it's oozing. It's
Oozing.
wet. The surface is wet because of the edema.
Here,
But it's
Sarah?
edema, edematous, right? It's edema.
Sorry?
It's edema.
Yeah. It's edema, and then this edema fluid comes out of the skin,
Yeah.
right? Because the fluid starts from here and then travels
So
through the skin.
would it still be considered a plaque, or would it be?
It's a blood. It's a blood. But you don't see overt scaling because this is oozing. This is edematous. It's very acute. And what could be the cause of this nice, beautiful shape you see here?
Strep?
Somebody tried a hair dye on their beard, right?
Oh.
This is exactly the
Keratin.
place of this hair dyeing. This again common things. In many parts of the world, men put dye on their beard to look younger, and they are much more commoner than ladies. They got this allergic contact dermatitis, maybe because this, when you dye your beard, the chemicals come in contact with your skin much more often than ladies that dye their hair, because they are not in contact with the skin, right? And what about here? Again, this is a little bit dark, but you will see again an erythematous patches on the side of the face, right? Again, something edematous, but this is basically on the side.
And they're patches.
Yeah,
It's
this is
really-
again a contact dermatitis, but here the reason is allergy to something like a shampoo, because they shampoo, they wash on the side of the face, and this is the most area that they have contact. So according to the shape of this, as I told you, this contact dermatitis is a big issue. Anytime you see a dermatitis eczematous reaction, the first question you need to ask, is it contact or not? And this shape and distribution, it gives you much clue. And what about here, what you see here?
Sunburn?
You can say a sun reaction, or better it could be a allergic or irritant reaction to the sun. But here you will see under the nose, for example, the area that, or inside the creases that they are usually covered by the sun is not affected. This is a photocontact dermatitis. Okay. So another disease related to follicular units is this Hidradenitis suppurativa. What happens here? This is related to the apocrine gland. So basically it's called acne inversa. Means acne, normal acne is on the face, chest back. When it comes to the body fold, the area that you have the apocrine glands, it's called acne inversa. What happens here? Again, first thing that happens is the occlusion of the sebaceous follicles, right? Yes?
I was gonna say that the
Okay.
apocrine gland.
And then the apocrine gland continuous secretion is distend the follicles, and in some point it ruptures. And the content of the follicle release to the dermis and cause inflammation. And there is some secondary bacterial infection come and sit on top of that. And these people usually have some impaired wound healing, and some immune dysregulation as well. So the inflammation takes a very long time. As a result of the chronic inflammation, you have tissue destruction, you have sinus formation, you have abscess formation, and because of the impaired wound healing, they lead to some sort of fibrosis, sinus tract, right? Yeah.
And nicotine is a cause of the inflammation for this.
Smoking is a very important environmental factor, right? Okay. So, at the beginning, it starts like this. A deep-seated, tender nodule in one of the major body folds, right? What could be the differential diagnosis here? This.
A wart?
It could be a folliculitis, a furonculosis, a boil, a skin abscess, right? This is a simple bacterial infection. The first thing we talk about that, right? So you may have some infection, bacterial infection, simple bacterial infection in the hair follicles. It looks exactly the same, like a boil. You will have some bacterial infection. But the story here is that it has a long-term course and chronic course, and then it's recurrent. For this reason, usually there is a gap between the appearance of the lesion and the diagnosis of several years, because these people go to this GP doctors and they describe this as an infection, they give some simple antibiotics, and then this story keep continuing, right? This is more common in females, and they usually are in the second and third decade of life. So it's a young female. So if the disease progress, then you will see slowly scar tissue develops, and then you have some sinus tracts, and then finally it involves the whole area. These lesions are very painful, and they have most of the time full smelling bloody discharge from them. So imagine, and they can happen, for example, in the major body fold, in the genital area, in the buttocks. These are the areas that you can see that one. Now imagine a young lady who have full smelling discharge from their armpit. It ruins their life, right? They can, even if they're in the buttocks, they cannot sit on the chair, for example, for half an hour. So generally, it is a disabling condition. It's a serious issue because of the age and the type of the people they are involved. Right? So we divided this hidradenitis suppurativa to 3 stages. This is stage 1, then you have separate nodules. In stage 2, you have some sinus tract, but there is some normal skin in between. And then this is the hardy stage 3, that's general involvement of the whole area. And there are different treatment algorithms based on the severity of that. One thing remember, hidradenitis suppurativa is not an infection. It's not. It's basically an unusual immune response to follicular occlusion and this content of the follicle, and then the bacteria is there as a secondary invader. For this reason, just simply giving antibiotics doesn't do anything unless you address some underlying issues, for example, like smoking or some modification in the lifestyle, like for example, if they are obese, reduce the weight. For example, don't wear tight clothing because friction, and for example, increased sweating can worsen the condition. Okay, we have a few minutes to talk a little bit about the depigmenting disorder. The prototype is this one. What is this? Vitiligo. So, what's the pathogenesis of the vitiligo?
No melanocytes.
Melanocyte destroyed by immune system. Which type of hypersensitivity? 4. Right? CD8 cells attack and then destroy the melanocyte. What is the age group of these people who develop vitiligo usually? Young people. And then usually there is genetic predisposition for this one. It's a common problem. Nearly 1 to 2% whole general population of the world, they have vitiligo. It is more problem in the communities who are dark skinned, because in white skinned people, vitiligo is not noticeable. In dark skinned people, it is a stigma. Right? And it can come in different forms. It can be generalized, affecting, for example, usually the acral area mostly, an area prone to trauma, or it can be localized, focal vitiligo, only one area, or it can be segmental. It covers, for example, one segment of the body, right? And then usually vitiligo is associated with other autoimmune disease. So anytime you find a vitiligo, you want to make sure that the patient doesn't have any other associated autoimmune disease, right? So there are some signs usually that shows that this vitiligo is active, it's growing. One of them is this called 3-color vitiligo. It means that you will see here the normal skin, you have here the white skin, and you have a little bit brownish in between. This, when you see this 3-color vitiligo, it is a vitiligo that's going to expand. So you will say that this is going to expand. And also sometimes you will see this confetti-like depigmentation. This is again a sign of the active disease. If you see this on the patient, it shows that the lesions are going to expand. Also, if you see the Kobner phenomenon, it's a sign of the expanding these are the signs that because when you want to initiate the treatment, you want to see whether it's in a stable vitiligo, the lesions are there, so maybe you go for repigmentation, or still it is active, it's in progressing phase, you want to stop the inflammation. So these are some of the mimickers of the vitiligo, right? For example, what is this?
Versicolors?
Versicolor. Fine scaling is there. What is this? What do you see here again?
Depigmented macule?
Is it depigmented or is it hypopigmented?
Hypopigmented.
Compare, for example, to this one, right? This is a hypopigmented, a little bit rough, scaly on the face of a child. This is pityriasis alba. This is seen commonly in atopic people. How about this? This is called guttate hypomelanosis. You will see tiny depigmented macules on the limbs, elderly people, as a result of the chronic sun exposure. And what is this one? This is, this is the wrist, right? This is the hand, this is the forearm, this is the wrist.
Scleroderma?
This is induced by doctor.
Allergic?
So again, on the joint especially, you can see that one. This is a post-inflammatory, or generally you can say post-inflammatory hypopigmentation, but here the inflammation is not the real one, because if you inject cortisone inside the joints, sometimes as a result, side effect of that cortisone, you may have some skin atrophy and hypopigmentation, right? So these are the things. Here, just ask the patient in history, do you have injected something here? They will say yes. So these are the mimickers of the vitiligo. Okay.
Albinism?
Yes. Which one is albinism?
Right side.
This one. What is this?
Vitiligo?
No. Just skip my mind, I will tell you. So this is the albinism is the genetic disorders of the melanin synthesis. So here we don't have any difficulty in melanocytes. The cells are there. Thus the different process of this melanin synthesis is genetically disrupted. Sometimes you have, for example, problem in transport of the tyrosine to the melanocyte. Sometimes you have problem in tyrosinase enzyme, right? And then sometimes, for example, you have some lysosomal disorders that, for example, this Chediak Higashi is one of them. It's a very common thing. Do you know Chediak Higashi? What is the symptom of the Chediak Higashi and what is the cause of that? This is Chediak Higashi. You will see that hyperpigment dilution, and these have genetic mutation, cause difficulty in lysosome trafficking, and if the lysosome is not working properly, for example, what can happen? Phagocytosis, right? So you are prone to bacterial infection, right? And then what happens else? Like platelet work by this mechanism. So you will have bleeding tendency, you will have bruising, you will have bleeding, right? And this is the Waardenburg syndrome. This is the autosomal dominant. You will see here clearly, it's the autosomal dominant. And the characteristic of this is this white forelock. You will see this white forelock, and this is from the birth. So these are the genetic diseases regarding the hypopigmentation. Okay. Yeah, this is the Waardenburg. Yeah. Okay. So what is this?
Alopecia.
Alopecia.
Areata. So what is the alopecia means?
Balding.
Hair loss, right? So whenever you have a hair loss, generally, first of all, you want to make a definition that whether it is scarring or non-scarring. We might draw a big line over here, right? And it depends on which part of this hair follicle structure is involved. If the involvement is the cycling part, you will have non-scarring because the stem cells remaining intact. If you, for example, if in alopecia areata, you have an infiltrate of the lymphocyte around the hair bulb. It's called swarm of bee, collection of these lymphocytes attacking the hair bulb. But because this is the hair bulb is affected, the stem cell is not affected, this is non-scarring. On the contrary, any diseases that affect this bulge area, when the stem cells are there, you will have scarring alopecia. It means that the hair will destroy permanently. It is non-reversible. And the scarring alopecia is a serious issue because if you don't treat it on time, then the hair, when it's lost, it's gone. So what happens in this alopecia areata? This is an autoimmune destruction of the hair follicles. You know that the hair follicles usually they have an immune privilege, means that they are not exposed to the immune system. What other organs they have immune privilege? Retina, cornea, right? They are immune privileged. They are not, the immune system does not have access to that one. And the reason here is that because of this regulatory T cells you have here and the milieu of the cytokines that prevent from immune reactivation. But any reason, like stress, like trauma, like these things, if this immune privilege is gone, then the immune system will recognize these antigens and start to attack them, and you will end up with something like this. This alopecia areata can happen anywhere. They are sudden, so you sleep not tonight, tomorrow morning you wake up and you will see, oops, one part is gone, right? It's very quick. Usually, sometimes you may feel a little bit tingling, itching, burning at the site of this. Not very common, most of the time it's asymptomatic. And then there is no sign of inflammation. No sign at all. Although this is autoimmune, but you don't see any sign of inflammation. No redness, no swelling, nothing. Just you don't see any hair on that one. It could be single patch, it could be multiple patch. And there are some signs that help you to diagnose alopecia areata. One of them is exclamation mark hair. If this is the surface of the skin, you see the hair comes like this. Thicker at the outside and thinner as we approach to the surface of the skin. This is called exclamation mark hair. It's a very characteristic sign of this alopecia areata, and it shows that there has been some inflammation going on around the hair root. Since melanocytes that are sitting in this hair bulb is one of the major antigens that targeted by the immune system, white hair sometimes doesn't affected by the alopecia areata. They are immune. So imagine a middle-aged person has a combination as white hair and dark hair. And because of the stress, because of this some external factor, develops a diffuse alopecia areata. What happens in a very short period of time, all the black hairs will shed. And what will remain?
The white hairs.
The white hairs. This is what happens to Queen Antoinette in 17 something. Right? So that was an alopecia areata because not you cannot change the color of the hair in one night. But if you have a combination of white and dark, and because of this stress, you develop an alopecia areata, the black hairs will follow. Same thing happens when this first hair start to grow, like this is the regrowing phase. First thing that they start to grow, they are usually white in color. And then later on they become blackish. So again, this is the common things that happens. We have some patterns of alopecia areata if they are diffuse. For example, they may affect only the back of the skull. This is called ophiosis. These are usually very resistant to treatment. And one of the other organ that is involved in the alopecia areata is these nails. So around 10 to 40% of the people with alopecia areata, they have nail problem. This nail and hair are cousins. So what happens here, they are related to each other. And the sign over here, most commonly is a peeling and is a regular peeling, right? I will show you later. So what are the treatment for the alopecia areata?
Shave it off.
Another better than that, beheaded, right? So get rid of the problem completely. So you can, because this is an immune reaction, you need to do something to stop this immune activity. So corticosteroids is one of the first line of the treatment. You can do intralesional injection, you can do, for example, topically apply, and then there are some, especially for the extensive lesions, that they have alopecia totalis or universalis. Totalis means the whole hair of the head and neck is gone, and the universalis means the whole hair of the body is gone. We have these JAK inhibitors that they bring a hope. So we have other type of the non-scarring hair loss. Remember again back quickly that we have this cycling I told you here on the hair follicle. In the anagen phase, you have the growing hair, right? And then on catagen phase, this part is shrinking. And then go to the telogen phase, resting phase, the club hair, the keratinized hair remain in place. And then when the new anagen phase starts, this again grow back, and the new hair will come out and push the existing hair out, right? This is called exogen. On average, if you have, we have around 100,000 hair follicles in our scalp, on average, right? And then because around 10% of them are in the telogen phase, it means that around 1,000 of them, 10,000 of them are in the telogen phase, right? And if the duration of the telogen phase is 3 months, nearly 100 days, right? Each day is normal to shed around 100 hair because this is growing and this is the hair cycle. But because they are spread haphazardly, right, randomly on the scalp, so it's not, you cannot see one area patches, bald patch, but this runs all over, right? Now, if for any reason this hair cycle destroys or interrupted or become much faster, you will come see some hair loss. These hair loss are non-scarring and because of the change in the hair cycle. For example, if you give somebody a chemotherapeutic treatment, for example, they have cancer and they take a chemotherapy that is very hardly affect the fastly dividing cells. What happens? The growth of the cells in the hair matrix will stop, abrupt, suddenly, right? And then the hair will fall out. This is called anagen effluvium, right? So this happens, for example, after the chemotherapy most of the time, and it is severe, it's happened everywhere, and it's very short. After in a short period of time, in a matter of days, 2 weeks after the insult, you will see hair loss. For example, you will see something like this, or even worse than this, go totally bald. If this insult is not that much strong, but pushes the hair toward the telogen. So for any stimulation or any disease or any sickness or whatever happens, high fever, their hair moves to the telogen phase prematurely. Then after 2-3 months, when the hair grow back to the anagen phase, you will see some shedding of the hair because this extra telogen hair start to shed. You will see a generalized thinning. It's called, for example, telogen effluvium. So here the telogen effluvium happens 2 or 3 months after the insult, usually not a big deal. But this anagen effluvium, it happens shortly because of the severity of this insulting event. And then we have here what? our old friends, androgenic pattern alopecia. It is a genetic hair loss that has generally two forms. The male pattern, and you will see this bifrontal recessing, and also bitemporal recessing, and also general baldness on the top. And then in female, usually they keep these hairlines. They is characterized by widening the part of the hair, right? Okay. So I think with this we are. This something that I showed you. These are the type of the scarring alopecia. These are seriously. For example, this is a lichen planopilaris. Lichen plant can affect the hair follicle and destroy this bulge area. So you will see patches. The skin is totally white. You don't see the opening of the hair follicles. And then this is non-recoverable. It will remain for the rest of the life. This is a discoid lupus erythematosus. This is another scarring alopecia. It's called CCCA in the people with black skin. So these are the scarring alopecia. Again, it's very important. If you see any hair loss, make sure that it is scarring and non-scarring. It's hormone related. It's related to the cell cycle. So, what is this?
Cystic.
Clubbing in the nails.
Clubbing.
Cystic.
How you examine the clubbing?
The beginning. If like it's a little higher than the rest.
How you examine? Do you have clubbing?
No, I can't examine.
Show me how you don't have. How you don't have?
It's flat.
You do like this.
Oh.
And if you see a little space between your nails, you don't have clubbing. It's called shimmer test.
Like you said, if you don't
Right?
see the space.
If you see this space, like a diamond space, you don't have. You just put, you see it, you don't
I
have
have a
clubbing.
diamond.
Okay, what is this one?
I have nails.
What is this one? This is called Booz line. Booz line, B-E-A-U. This isn't in your presentation.
Oh.
Same story I told you about the hair problem, that if you have any insult, the hair growth will stop or suddenly goes to the telogen. Here again, if you have serious disease, serious illness, high fever, operation, there will be a sudden or short stop in the cell division in the nail matrix. And then when it grows back, you will see a mark of this on the nail. And because the nail grows something around 0.1 millimeter per day, so if you measure this distance and it is, for example, around 5 millimeter, you can tell to your patient that, by the way, do you have any operation, anything serious illness, around 2 months back, and say, yeah, how do you know? This is the sign, right? It could happen in one nail or in several nails. What is this one? Spoon nail, right? If you put a drop of fluid, it remains there. In normal nail, if you put, it will split. If you put, can keep the nail, a drop of the water inside, this is spoon nail. And which disease is called spoon nail?
Iron overload. Iron.
Iron deficiency anemia, yeah.
Deficiency.
And what is this one?
Splinter.
A splinter hemorrhage, right? What's the cause of the splinter hemorrhage?
Trauma.
So trauma is the very common cause. If it's a single digit, in some diseases, skin disease like psoriasis, you may have again splinter hemorrhage. But what is usually asked in the test is the bacterial endocarditis that can cause splinter hemorrhage. This is the shape of the splinter hemorrhage, right? And here is the pitting, right? So here is a coarse pitting. You may see in the course of, for example, the skin disease. This is a fine regular pitting, is alopecia areata. What is this one? This is a separation of the nail plate from nail bed. It's called onycholysis, right? It could be idiopathic, it could be from the irritant, it could be from the disease, it could be from the fungal. So in the simple form, you will see just opaqueness of this nail plate because it's not attached to the nail bed. So here the redness you will see is because of the nail bed, right? So if it is separated, you will have some air inside, and then you will have this opaque appearance. And what is this? Any of you have this white spot on the nail?
Yeah.
Right? It's called leuconychia. This leuconychia means white spot on the nail. And what is the cause of this? It is parakeratosis and some air pocket inside the keratin layer. It can be on one single nail that could be traumatic. People who bite their fingers, they may have something like that. Or, for example, it can come with other conditions. There are a list of these leuconychia that comes with the systemic diseases like Muher's line, like half and half nail, like a Terry's nail. These are all in this presentation. You go through this because later on when you go to the systemic diseases, some part of this is this sign that you can find on the nail. As I showed you, this kind of skin, hair, and nail signs help you in diagnosis systemic diseases and guide you toward the underlying condition. Okay, I think this is my last slide for today. So, first of all, any questions from the whatever I talked today, the day before that? Anything to clarify? Any questions, related, unrelated? So I hope that everything is so clear. Yes, ma'am?
You promised to share with us the book.
Yes, it will be. I will be. So at the end, please, one of you that is tech guy, come over here because it's a PDF in my iPad, so you have to transfer somehow. I don't know how. So I cannot send it by email, but it should
drop
be.
it.
Okay, you do something, whatever I will tell you. And then it was a great pleasure for me to meet you all. And then you have a very bright future ahead of you. Just remember that this medicine, take everything seriously because later on you will be responsible for the most valuable asset of the people what is their health, right? It will be your hand. So there is no room for not being able to treat them, not providing the good service, right? So this is very important. Take it seriously. Anything you learn, try to understand why you should learn this one and how it's going to work for you. Because as I told you, there is not unnecessary information. Everything here has a meaning. So try to understand that. It makes things life easier for you. Try to connect the dots together so you can connect different things together. And I truly, from deepest part of my heart, wish you all the best in your career. Again, it was a great pleasure to meet you. And then these people over here has my email, my contacts. So if later on, if I could be of any help, please contact me. Don't hesitate. And if you are okay, we can take a group picture together, right, as a memory of this session, right? Okay. So let's take the picture as well. Thank you so much. Who wants to take the picture? Or can we call somebody to take a picture from us?
Yeah, we'll call.
I'll take the picture.
No, we'll call one
Yeah,
of the.
yeah, hey, all of you be there. Yeah, it's a nice
I'll
thing.
take it.
Okay,
Transfer,
yeah.
the transfer